I'm Dr. Suresh Ramalingam, medical oncologist from the Winship Cancer Institute of Emory University in Atlanta. How do we select appropriate therapy for ALK-positive patients in the first-line setting? To answer that question, we need to really look at how fast we've moved in this subgroup of patients. ALK-positive non-small cell lung cancer accounts for approximately 4 to 5% of all patients with lung adenocarcinoma. This fusion abnormality is detected by a number of methods. Some institutions use immunohistochemistry, some use the FISH test, and with the NGS profiling, fusion abnormalities are detected as well. And now more and more testing companies are also using RNA-seq as a way to detect ALK. The most important first message is we need to check patients with lung adenocarcinoma for driver mutations and fusion genes before we start any therapy. Once we have ALK confirmed in a patient with advanced stage lung cancer, then it is very clear from multiple randomized trials that ALK tyrosine kinase inhibitors are better than chemotherapy in the frontline setting. So we would choose an ALK TKI. The first ALK TKI to be approved in this space is crizotinib. And crizotinib has a response rate of 60%, has a median PFS of approximately 8 to 10 months, and it became the first standard of care for ALK-positive patients. Now, crizotinib has suboptimal brain coverage. In other words, brain metastases cannot be sufficiently treated with crizotinib. Take that with the fact that nearly 60 to 70% of ALK-positive patients will develop brain metastases during the course of their illness. So all of these factors resulted in the development of a newer generation of ALK tyrosine kinase inhibitors, or the next generation ALK inhibitors. Among these include ceritinib, alectinib, brigatinib, and more recently, lorlatinib. All of these agents have been compared in randomized trials to standards of care and have shown benefit. Ceritinib was compared to chemotherapy and was proven superior. Alectinib, which is one of the more commonly used ALK TKIs, was compared to crizotinib in 2 randomized phase 3 trials. One was conducted in Japan, another one conducted in the rest of the world. And in both of these trials, alectinib showed significant improvement in median progression-free survival, almost to the order of 10 months in the control group and 25 months with alectinib. Alectinib was tolerated well and also has good brain metastases coverage. So it is one of the more commonly used frontline agents. We also have 2 new agents. The next one is brigatinib. Brigatinib is also a next generation ALK inhibitor. This has been compared to crizotinib, and the results were uniformly impressive, just as we saw with alectinib. So brigatinib is approved. One of the main adverse events of brigatinib is that early on in the course of treatment, especially in the first few days, a small percentage, 3 to 4% of the patients may develop pneumonitis. So you start with 90 milligrams per day. If the patient tolerates it, week 2 onwards, you can go up to 180 milligrams per day. Brigatinib also has excellent brain activity. Now, lorlatinib was initially approved as salvage therapy for ALK-positive patients after they had progressed on a prior TKI. It has very good brain penetration, and it was approved in the second-line setting. Now, a large randomized trial called the CROWN study has compared lorlatinib to crizotinib in the frontline therapy setting. The median progression-free survival was substantially better for patients treated with lorlatinib, and the hazard ratio was 0.28, which was much more favorable compared to the kind of hazard ratio we've seen with alectinib and brigatinib. So very recently, lorlatinib has received approval in the frontline therapy setting. So we have a multitude of options in the frontline treatment setting. And the question is, which is the best agent available? To me, we can make a case for using any one of these agents. Lorlatinib, each agent has its own unique toxicity profile that one needs to be aware of. And the decision-making comes down to having a conversation with the patient about pros and cons of each of these drugs. One additional advantage of lorlatinib is if you use another ALK TKI in the frontline setting, like ceritinib, brigatinib, or alectinib, when patients progress, you can use lorlatinib. However, that should not stop us from thinking of lorlatinib in the frontline therapy setting. So it's a good time for ALK-positive disease with multitude of options. And the best approach is to personalize therapy based on patient-specific factors and patient preferences.